Yes, sir. We are live on YouTube, sir. Welcome to the Indian Arthroscopy Society Academic Corner, September 2024 edition. Today we have with us Dr. Karthik Selvaraj sir and Dr. Jaimin Jayaselpura sir for as moderators. We have expert talk by Dr. Clement Joseph sir and presentations by Dr. Mahesh sir and Dr. Pramod. I welcome you all once again. I would like to hand over the proceedings to Dr. Karthik sir and Jaimin sir to take over this month's IS Academic Corner. Over to you, sir. Karthik sir, please.
Thank you, Naresh bhai.
Thank you.
Good evening, all. Welcome, sir, Clement Joseph, sir, and presenters. Karthik bhai, hello. Dr. Karthik?
Yes, can you hear me?
Yes,
sir.
yes.
We are able to hear you, sir.
Yeah. So,
Yes, Jamie, go ahead.
Yeah.
Hello?
Jaimin sir, please go ahead, sir.
Yeah, so today's meeting is focused on technical note from Dr. Clement Joseph, sir. And we know that it's one of the very good procedure of lower trapezius transfer, which has had been chronic irreparable rotator cuff tears. So we would start with, and we have got two more talks. One is a case presentation from Dr. Pramod Mohan, and we'll have regarding neglected shoulder dislocation with anterosuperior cuff tear. And the second case presentation is from Dr. Mahesh, and regarding the management of different methods for neglected posterior shoulder dislocation. So I would like Dr. Karthik. So can you just narrate a bit about the LT transfer and invite sir to go ahead?
Well, I will take this opportunity to thank IAS on my behalf and Jaimin's behalf ask us to moderate this webinar. And this is a regular event IAS, and it's been going on very systematically with a lot of followers. So thanks very much. Myself and Jaimin are part of the Shoulder and Elbow Society of India. So Jaimin is the executive committee member, and I am the current secretary. And I take this opportunity to urge each one of you watching this webinar to also become SESI members. And SESI also does journal clubs and other activities like this. Naresh, you don't mind,
Sir, I am already member, sir. I am already member.
Fantastic. So, and we've got none other than Dr. Clement Joseph, master from Chennai, who's going to show us about lower trapezius transfer. And following which, we got some excellent talks as well, as Dr. Jaimin said. So, without further ado, we'll listen to Dr. Clement. Welcome, sir.
Welcome. Thanks, Karthik and Jaimin, Naresh, and it's honor to be part of this meet. And let me share the screen. And it's a very common situation in India that people accept for surgery at a very late stage. But when they actually willing for surgery, when they accept the surgery, it may be too late. The tears, especially the rotator cuff tears, may be retracted. The tissue may be very poor and atrophic. So many times we won't be able to achieve what we intend to do. So this is a good option in treating irreparable tears, the lower trapezius transfers. So this is my intention in this to
Sir,
make it
please
simple
make it
for you.
slow, sir. Yeah.
So in the talk, I will propose irreparable cuff tears and the tendon transfer as a joint preserving option, and break the myth that tendon transfers are very messy and difficult. It is actually an easy surgery, and also it is reproducible when compared with an arthro-letarge, where only very technically sound people can do it. This technique can be reproduced by anybody who's got a basic shoulder skills, and also we'll go through some of the technical steps involved in this procedure. And It's amazing that how our shoulders can compensate for loss of muscular tenderness deficiency. For example, look at this patient, a 10-year-old injury. It happened because of an epileptic episode due to aneurysm. He's an ENT surgeon. So look at his shoulder here. So totally gone up, and the tendon is retracted. And many people would advise a reverse shoulder at this stage. But look at his functional adaptation. He plays tennis daily, and he's able to swim twice or thrice a week. So, so this was an eye opener for me to know that how much a shoulder can compensate, and hence we need to keep the reverse shoulder as an option at select cases which are totally irreparable and arthritic. And many cases, if you anticipate the problems early, we may be able to correct using the tendon transfers and joint conserving options. So basically, one has to understand the function of cuff is something similar to keeping the ball down in the water with two hands. All you need is two hands, and however far apart they are, as long as there is an anterior and posterior force couples are there, the head can be pushed down so that the deltoid can act. So it's very, very important to ensure that the shoulder has an anterior and posterior force couple. That's why many times, even when you do a partial cuff repair, just attach the infraspinatus partially. The shoulders can get a reasonable amount of movement. And very important points to observe when you're dealing with cuff tear is range of movements, passive and active. And one has to have an active elevation of at least a 70-degree to consider tendon transfer options. Sometimes when the patient cannot even lift the arm, one has to rule out axillary nerve injury and also pseudoparalysis. And severe cases of pseudoparalysis may not benefit by tendon transfer options. And one has to make sure that the subscapular is functional and intact, and one should always look for winging of the scapula, which can indicate malfunction of serratus anterior. And axillary nerve function is very, very important for, especially when you are considering for reverse shoulder. So these are the crucial clinical points which you have to look for. Just don't just go with an MRI finding. Always examine the patient to look at the stage of the disease and to what you can offer him as part of the treatment. And what is an irreparable tear? These tears are those which can't be brought to the footprint even with 60 degrees of abduction, despite releases and mobilizations. And also included are tears with poor healing potential. For example, if you look at an atrophic muscle belly with a lot of fatty atrophy, even if you are able to bring the poor quality tissue to the footprint, these poor quality tissues are likely to fail. And massive tears are those who are more than 5 centimeter in dimension, which involve more than two tendons. So one has to remember all the irreparable tears are massive, but not all massive tears are irreparable. Just because we have tendon transfer options, one should not miss out on the opportunity to try to mobilize and do a partial repair in addition to the tendon transfer. So you have to make a genuine attempt to repair the tendon tears. Don't just jump into the tendon transfer options. So this is an important point in my practice. So first thing, always suspect irreparability when you see a retracted tear. And then when there is a severe fatty degeneration, even if you're able to bring the foot tendon to the footprint, most of the tears are likely to fail. So higher grades of fatty degeneration, one should be prepared to add lower trapezius tendon transfer as well. And considering the therapeutic options for massive irreparable cuff tears, so there are so many options have been proposed, and including partial repair, adding biceps SCR, and latissimus dorsi was popularized by Christian Gerber, in which we bring the latissimus dorsi, which is basically an internal rotator of the arm, and you transfer to the back of the shoulder to make it function as an external rotator and depressor. So here you have to re-educate, readapt to the new function of the muscles. So basically, when you want to relearn and re-educate, this latissimus dorsi transfer work better in patients who are much younger, and mostly the elderly patients historically didn't have very good result with this transfer. And also, Karthik and other seniors may tell that how messy this procedure is for beginners. On the other hand, the lower trapezius tendon transfer, you can see in the picture, it is the line of action is almost similar to the infraspinatus, and also it is very easily accessible, and the landmarks are very much palpable. And all you need is to palpate the tibial spine and the lower third of the medial end of the scapular spine is the attachment point for the lower trapezius. You can detach the lower trapezius from the spine and you can mobilize it a centimeter or two towards the shoulder, but you won't be able to bring the tendon to the great tuberosity where you want it to attach. So you had to do an extended graft transfer so that the tendon action is brought onto the shoulder. So historically, the Americans were using allografts like split tendon, Achilles tendon allograft. But in India, since we don't have that much of access to the allografts, we've been using semitendinosus to start with. Nowadays, I use the peroneus longus tendon, which can be easily harvested. So in a nutshell, when you advise a patient and you also suspect that tears may be irreparable, so you can mentally prepare the patient and counsel them about the need for a procedure in case the preoperative findings, suggest an irreparable cuff tear. So the consent is usually obtained beforehand itself, so that you don't have to tell the patient that he has to undergo a second surgery sometime later. And since the peroneus tendon is easily accessible, you can drape in an easy way, which I'll be showing later. So when compared with the biomechanics of lower trapezius transfer and lattice methosis transfer, and you can see here, based on the biomechanics studies, the lower trapezius has the largest external rotation moment, and the latissimus dorsi may be better when the arm is abducted. It's a better external rotator when the arm is abducted. For example, a young active individual who needs to do a lot of overhead activities may benefit from a lower latissimus dorsi transfer. But an elderly person who wants to regain his external rotation and regain some elevation, probably the lower trapezius is a much easier surgery to carry out. And once again, the same points which I told, it's the same phase like infraspinatus. It's already, it can easily act as an external rotator. And probably when you do a lot latissimus dorsi transfer, you have to educate and rehab. It's very, very important. Many patients take months to regain the elevation and external rotation after this transfer. So technical pearls, my preferred graft now is peroneus longus, and sometimes I can also use semitendinosus. And the most important technical part is the harvest and identification of the tendon could be troublesome, especially in an obese and flabby patient. So it's very important that you have to identify the anatomic landmarks, and usually there will be a big wad of fat below the skin. So you may have to excise the fat pad so that you have access to the medial end of the scapular spine so that you can harvest the tendon easily. And I always add a biceps SCR if the biceps tendon is found to be functional and of reasonable health, to act as a superior static restraint and also to act like a static anterior cable. And also, an effort should always be made to bring out the part of the infraspinatus. It can be repaired to the footprint or it can be repaired partially to the tendon. So this is my internet here. And coming to the prerequisites for the surgeries, the patient should have an active elevation of at least 70 degrees. It should have a functional subscapularis. There should not be winging of scapula. The joint should not have any arthritic changes and it should have very minimal proximal migration. So all these points have to be assessed clinically and radiologically before you undertake. Case where severely painful shoulder, 4 months duration, it's able to abduct, but very painful. And is a manual laborer. He won't be able to, make his functions after a reverse shoulder, also economically challenged. You can see in this MRI, the proximal superiorly, and you can also see there is a subscapularis tear. We've been discussing that subscapularis function is intact. In this patient, we went a step ahead to try to repair the subscapularis as well as do trapezius transfer because of the recent nature of injury here. And also you can see the tendon is retracted and there is a significant fatty degeneration in this patient. And this is how we position for the irreparable cuff tears. Both the shoulders and below the knee are exposed and draped. You have to mark the bony landmarks, the scapular spine, acromion, and the clavicle, everything is marked. And the entire should be accessible from the back. So the midline, so that the entire half of the shoulder from the midline is And this is a video of how to harvest. As you can see, this is the outline of the scapula, the medial 4 to 5 centimeter. You can make an incision along the line of the spine of the scapula. And once you make the incision, you have to undermine a little bit, and you have to remove a good chunk of this fat. So otherwise, it will be very difficult to see. Once you remove the fat, you can see the muscle fibers, and just below the spine, just using the that flap is elevated. And once you reflect the flap of the tendon, you'll be able to see the aponeurosis, a shiny aponeurosis below. So that indicates that this is a lower trapezius tendon. So usually it's a triangular tendon. And what you are doing nowadays at this stage is to tubularize the tendon using number 2 fiber wires. And then at this stage, you can pass an instrument from this wound all the way into the posterior superior aspect of the shoulder. This instrument can be seen uh, using arthroscope, and you can always pass a loop of sutures from the joint outside so that the tendon can be taken into the joint. Okay, usually the loop end is taken into the joint, and there are two free ends which can be one of the ends is taken through the tubularized tendon here, and then it can be looped over and sutured back to itself and also to the lower trapezius tendon. So this is the action that happens on the tendon harvest site of the lower trapezius. Okay, so let's go to the next video to see the intra-articular picture here. And this is a patient which we saw in the illustration. As you can see here, the cuff was totally retracted to the level of glenoid labrum. Absolutely, you can't bring it, mobilize or do anything. And same steps as we told, the lower trapezius tendon, the triangular tendon is harvested from medial 3 centimeters of the scapular spine, and it is tubularized with the number 2 fiber wire. And then you have to prepare the subacromial space, and in this case, loaded anchor in the anterior part of the footprint, and you can see the bicep tendon here. So I'm going to use one suture to pass through the bicep tendon. So one suture passage is usually not enough. You have to pass multiple sutures, so at least so that the bicep tendon, and then the bicep tendon is attached to the anterior part of the footprint. So this recreates your superior capsule or an anterior cable, whatever you like to call it. Then the next step is to create a soft tissue pathway just infraspinatus and the deltoid. Here you can see the infraspinatus, which is retracted all the way to the glenoid, and then using now you can see the long artery forceps which has been passed from the spoon into the joint. You can see it is entering the joint posterior superiorly. Then a loop joint using relay techniques. You can pass one of the switches from the anchor into the loop. Here you see I'm creating some microfracture for healing response of the graft. This tied and we are going to use another suture anchor to fix the graft to the posterior aspect of the footprint here. So this is a suture tying happening on the anterior part of the footprint. This is the second posterior anchor in the footprint. And once again, you can use a double loaded anchor here, and you can pass the sutures around the tendon, and you can fix the tendon onto the graft. Now comes the important part. Here, one end of the tendon is taken into the tubularized lower trapezius tendon, and then it is folded back and sutured onto itself, while the assistant holds the hand in 45-degree abduction and 60-degree external rotation. And then multiple sutures are made to fix the tendon to the lower trapezius as well as onto itself. And in this patient, we did an open subscapularis repair as well, and he was able to lift the arm nicely, and he was able to return back to his manual labor job. Yeah. And so far we have done nearly around 20 patients. The results, you can see a significant improvement in the scores in our study, and it's technically very simple. Once you do 2-3 cases, actually it's technically becomes easy for us to do this. So to conclude my talk, always suspect irreparability and potential failure when you're dealing with chronic tears in elderly and refractory tears. And always discuss the possibility of need for a lower trapezius tendon transfers with your patients, and get consent, and expose the shoulder and lower limb in your rotator cuff repair cases. And just don't take this as a very difficult surgery. Actually, it is easy. You're prepared and you learn regularly. And it is for everyone. It's not only for people who are technically very smart and sound. And it has got a short learning curve. And in my opinion, adding a biceps SCR to the anterior anchor adds 10 to 15 minutes of your work, but tremendously improves the results. With this, I conclude my talk. And once again, I thank IA Corner as well as Naresh and team for the invitation. Thank you very much.
Thanks for the excellent talk, sir. Can you hear me?
Karthik.
Yes, sir. We are able to hear you, sir.
Yeah, I can hear you.
Sir, do you do superior capsular reconstruction?
I was doing, but I kind of switched over in 2017 to biceps this year, and from 2021 I've been doing lower trapezius transfers. And so far my need for SCR has been very less. But in my opinion, the only indication for SCR would be uh, functional shoulder with a lot of pain with anterior superior cuff deficiency. When there is a posterior superior deficiency with the loss of external rotation, I think.
Hello?
Clement, sir. He got disconnected, sir. 1 second.
Yeah. I'm sorry about it. Some issues here. Karthik, what you do the technique, or what's your technique? I think you are a big replacement surgeon. And what is your indication for this tendon transfers in your practice?
Sir, I do tendon transfers for Hamada type 1, type 2, where there is a loss, when there is no arthritis, glenohumeral arthritis, or stabilization of the humeral head. There is actually no indication to do a reverse shoulder. Now, the problem is we are getting more and more results of reverses in problem. There can be long-term failures, especially if the design is changing so rapidly. So under 70, Hamada type 2, there is no stabilization, no glenohumeral arthritis. We should try to salvage the joint and go ahead and do a lower trap transfer. I quite lower trap transfer. In fact, I don't do much. But how far would you like to push the? Would you? How do you decide preoperatively or what you're going to do in that?
Sir, Karthik, sir, your voice is breaking in between. Please try to be uh, small. Ask in small sentences. Internet is slow, it seems, sir.
Can-
No, sir, we are not able to hear you, sir. Sir, Jaimin, sir, in between, Do you need any questions, please?
Yes, sir. Can I ask one question? The first case of that ENT surgeon, which you showed us in a video, that he was compensating very well. So can we accept this procedure even with a mild arthritis, as the shoulder not being a weight-bearing joint, and to give it good stability and function, even in early arthritic changes of shoulder joint?
No, for that surgeon, I didn't recommend anything. He was doing very well.
Perfect.
Let's not touch anything. But for early arthritis and painful arthritis, probably in younger patient, maybe we can try. But above 65, 70, I would be very, very careful. But even as in the knee joint, it's a joint preserving procedure. So you should be aggressive when the patient is young and active. And as they become older, 75 and above, I have done this up to 8 years also. The results become worse after 75, follow trapezius transfer. So in that case, probably you have to, in some patients, I've done just a tenotomy. See, irreparable cuff tear, severe pain, didn't do anything, just tenotomy. They had cardiac issues, everything. They're quite happy. Okay. So you have to be very judicious in selecting the patients. Above 75, you have to be very careful, try to do conservative measures, stenotomy, injections, rehab, like that. And there may be a situation those patients end up in having severe pain, many months of therapy, then they'll be acceptable for the reverse shoulder. Okay. But if you are less than 65, 55 like that, don't jump into reverse and try to do, and once again, you have to do repeated evaluations. Just because the patient is not able to elevate the arm, it doesn't mean pseudoparalysis. Just give injections and see. There are many times where you see Hamada 3 after acute tears. Okay, there are no preoperative symptoms. The X-ray looks very bad, and we are able to repair and bring it down also. So just because there is a Hamada 3 or 4 or the patient has got a pseudoparalysis doesn't mean they are bound for reverse shoulder. Give subacromial injection to see whether the pseudoparalysis is because of pain, and then see if the X-ray is properly taken. And the younger the patients, the more aggressive should be your efforts to save the joint. Elderly patients, probably you don't want to commit to a major surgery like this. Probably you want to do something little injections, therapy, and then probably maybe go for a reverse shoulder. So above 70, you have to be careful. Yeah.
Thank you,
Can
sir.
you hear me now? Can you hear me?
Yeah.
We are able to hear you, sir. Karthik, sir. Yes, sir.
So I'm
Yes,
sorry for the interruption in between. Actually, I'm sorry. No, I think Clement sir made the point what I was trying to make. So as even though I like to do reverses, in case of a massive cuff tear without rotator cuff arthropathy, by arthropathy I mean astabilization of the humeral head, which means chronically there is a superior overriding of the humerus, and then any glenohumeral arthritis, then it's a clear-cut indication for reverse. Otherwise, it's very, the West might try to sell the reverse to all these patients, but 5 years or 10 years down the line, we are going to face the music. We are going to face all the complications. So better to salvage the joint whenever possible and not to jump into a joint replacement if there is no arthritic change. So I was going to ask Clement, what do you do to a young patient where the subscap is deficient? So how do you deal with that? In this patient, in fact, you actually repaired the subscap and then did the low trap transfer. So, we all know, BASM actually advocates LD transfer for the subscap. Now, have you had any experience with dealing with the massive subscap there, along with the
No, no, Karthik, I have not had any cases like that. But technically speaking, based on what is being practiced, I think the latissimus dorsi transfer is more appropriate for irreparable subscapularis tear because it is a natural internal rotator. And if you're able to do a subscap, compensation by using an LD transfer, it would be one of the choice here. But I never had any patients like that. Yeah.
Sir, Dr. Neha is there. She wants to ask a question. Dr. Neha, please go ahead.
Yes, sir. Good evening, sir. Dr. Neha here. My question is, where you would not advise lower trapezius transfer in cases of massive rotator cuff tears. In which patients, rather than in arthropathy, except arthropathy patients, where you would not advise?
Obviously. Yeah, good evening, Dr. Neha. Uh, Basically, we stick to the same points which have been discussed here. If the patient has a severe pseudoparalysis, not able to lift, probably I will think twice, and the subscapular is not working. That's very, very important thing. Subscapular full should be there. Apart from that, chronic cases, probably you may have to rule out a brachial plexus injury, because many times it can coexist with these patients and axillary nerve function. So routinely, many times when you have doubt clinically, I do nerve conduction study also. So basically, the same points stay that arthritic patients and patients with pseudoparalysis who are not able to lift the arm even after 60-degree, probably I would think twice before we do this. Yeah.
Can I add
Anything else which you want to contribute, Karthik?
just one more? Sundar sir is also there, and you are there. You actually would like to fix it with suture anchors on the top of the humeral head, right?
Yeah.
There are certain procedures described with endo buttons as well, which also seems quite easy and straightforward, where you can just loop the tendon through the endo button and flip it in the anterior part and you can use either a guide or you can drill it. Have you tried that?
No, I'm a bit kind of worried to make a tunnel in that part of a bone in 65-year-old female because you can easily have a bloat. And many times when you put an anchor, Karthik, you don't have to hammer it also. The the spear just goes inside, right? So I'm worried how the endo button is going to stay on the cortex. That's one thing. And if you're making a tunnel from back to the front, what happens if the tunnel blows out? There is a cortical opening. It may be a big trouble for me to handle. And this one helps me in two ways because I put two anchors. The portion which sits on the footprint acts like gives like a balloon effect. It acts like a spacer as well. And the posterior anchor is going to fix the tendon posteriorly. So it effectively makes it to act like an external rotator. So both it gives a spacer action as well as an external rotator function also if you use the actually this is much more easier I would say in my opinion. But there have been techniques, but I have not tried them once because I follow Basamel Lawson's technique of using anchors. But only thing I use knotted anchors. I don't use a knotless anchor here.
Okay, I have actually used the endo button a couple of times and it's quite straightforward as well. Sundar sir, what do you do?
So I use same like what Clement said. I'm using over the top or the footprint. But as I said, Clement said, the multiple point of fixation anchors the graft very well from your anterior to posterior direction, the entire footprint. From the two lateral knotless anchor from the anterior end, then I row medial row and lateral row. It holds us very well. I mean, I know few of them are published with the good results with endo button too. So probably the bone quality is good. I think definitely it will work well. They say that mechanical strength is better, but I'm not sure about it. Coming to the Naga's question, when you're not supposed to do a lattice mesh transfer, most of the time when you say 10 patients lattice mesh transfer, we do only one patient. So you should not go jump into the big procedure. And I think Clement might have told you very well that you have to try to repair infraspinatus. If you do a good infraspinatus repair with probably the biceps SCR, most of these patients that do very well. So unless you are not able to even repair partially, partial repair, if you have to do infraspinatus, you are not able to complete your even infraspinatus repair. If the fat infiltrations muscles are good, if the subscap is intact, maybe they are the only cases ideal for the lower trapezius transfer. So if you think 10 cases for the latissimus transfer, probably you'll end up with, sorry, lower trip transfer, you'll end up with in one case only. We counsel the patient, but by the time when you go inside, you'll be able to repair infraspinatus. I think
Yeah,
Clement also have that.
yeah, it's the same. Many times our residents will be frustrated that we didn't know that we prepared.
That is true.
It took so much of time. And patients also will ask after they come out of and say, "Sir, did you take the leg muscle?"
Yeah.
And they, no, we have to say. So, as rightly said, you have to make a genuine attempt to mobilize the tendon, and you have to make a genuine attempt to repair, even partially, even after you do lower trapezius, repair the infraspinatus stump to the tendon or to the footprint. It greatly improves your result.
So we have to take the technique from Basam, but we should not follow all the principles because he doesn't do a repair of infraspinatus at all. You just go take the graft, put it inside. He doesn't see what is there at all. So that is not the, I don't know, I don't agree with that principle of not trying to attempt, I mean, not attempting to repair the infraspinatus. As Clement said, we try to do mobilize the graft and I mean, infra, most of the time you'll be able to repair it back so we can avoid the big surgery.
So
Because
it's
Basam is
mainly
a quick
intraoperative.
content transfer guy, so he does all the, I mean, he does with such a ease for all the cases and claims good results. But we have to be very, very cautious in doing this a big procedure.
So it's mainly intraoperative decision, you can say.
Yes, no, yeah, intraoperative, yes. But we will preoperatively counsel the patient. It can be an irreparable. So you have to counsel the patient. Anybody with the 4 centimeter traction, I think all the Clement had told the point. So you have to
Yes.
counsel the patient. So if we go and mobilize the infra and if you could repair it well, then you don't need to do the lower trip.
Yes. Thank you.
Thank you.
Just one more last question.
Yes, sir.
Clement, sir, you got a good series. You got almost 20 patients, I think. So, have you had any ER lag in those patients and preoperatively? And what is the how much has the power come back after tendon transfer?
No, this one was done by my junior consultant. Unfortunately, we took the constant. We didn't take the constant score. So clinically, we were able to have a very good improvement in external rotation. But in this series, I think they used a dash score and UCLA score, so that didn't document the power. So we are going to rework on the next patients to document the external rotation power. But if you ask me clinically, I would say there is an improvement in external rotation. The younger the patients, more. We had issues only with patients above 75. Two of them, which we did, so they didn't gain that much of function, I would say. Younger patients usually they do very well, but the most important thing is the angle in which you're going to fix to the uh, lower pieces to the tendon graft. Do you have any preference, Karthik? Which angle do you follow? Sundar sir, what angle do you fix? You rotate fully or you rotate 60 degrees or you abduct 20-30 degree or you abduct 45 degree? Which angle you keep the arm when you're tightening and fixing the graft to the lower trapezius?
So I kept around 30 to 40 degrees of abduction and almost in slight external rotation, not the full external rotation, not full internal rotation. So with the 30-degree abduction with where you put that abduction pillow, the same angle I try to fix up in all the cases.
Okay.
Yeah, I think you are doing it in lateral position. I do it in the beach chair. So I usually keep it at 20 degrees because don't use I use John Joy sleeve for I don't use that,
Yeah, we do it in beach chair only. I think
20
Clement
degrees,
also.
just 20 degrees. Because,
Yeah. Your voice is breaking.
so it can't be very but because so 20 degrees what current. There are no more.
Sir, we'll take a last question from Dr. Mahesh and we will move on to the next talk, sir. Jaymin, sir.
Sir,
Yeah,
good
sure.
evening, sir. Dr. Mahesh from Karnool. Sir, lower trapezius transfer mainly acts as external rotate, which is acts in place of infraspinatus. Does it have any action in abduction, sir? Does it help in initial abduction? Will it replace the supraspinatus function
Dr.
also?
Mahesh, your voice is not clear.
Sir, lower trapezius mainly acts for infraspinatus. Will it helps in supraspinatus action like abduction also, sir?
Yeah, it will help because you're going to re-establish the force couple. Okay, so once
Yes.
there is a anterior force and posterior force couple are balanced, the deltoid will be able to abduct it very well. So in some cases, I have a lateral acromioplasty to make the deltoid more efficient. I remove a lateral 8 millimeter to 10 millimeter of acromion so that the deltoid action is slightly more oblique and then it can function better. So this is one trick which we can do
I
for
Thank
think,
you, sir.
abduction.
I think for that point Clement told, I think Clement already answered the question that you should have reasonable function before you do a lower trip transfer. At least the elevation should be at least you should have around 50, 56 degree. If it's a pseudo paralytic hand, then it may not work.
Thank you, sir.
Thank you.
Thank you, Clement Joseph, sir.
Thank
It was an excellent
Thank you.
talk and a very good insight about the right indication for this surgery and uh, in which position we need to fix it for to get the optimum result. I would like to invite our Dr. Pramod Mohan for his case presentation on neglected shoulder dislocation with anterosuperior cuff tear and frozen shoulder. Dr. Pramod Mohan, can you share your screen, please?
Yes, sure, sir. Sir, am I audible, sir?
Yeah, you are audible and can be seen, visible as well.
Sir, is my screen visible?
Yes, yes.
Okay, sir. So good evening, one and all, and I thank this opportunity. I just to take this opportunity to thank all IAS and IAS members for giving me this opportunity to present this case report. So, and apologies from my side. So my topic is actually the traumatic shoulder dislocation. It is complicated with anterior superior rotator cuff tear and frozen shoulder in a middle-aged active male. So coming to the case history, so the patient was a 50-year male who was a physical training teacher by profession. So he sustained a road traffic accident exactly 6 months back presentation, and he was diagnosed with shoulder dislocation, for which he went to a local hospital where the close reduction was done. But the patient continued to apply the sling for 3 weeks, and he continued to complain of pain and weakness even after 3 weeks of time. So the doctor suggested him an MRI, but the patient was not willing for MRI and he went for a native treatment. So the native treatment bandaging was done for next 3 months, and then he tried physiotherapy with no benefits. So he came to us with complaints of severe pain, weakness, and restriction of movements. So then we advised an MRI for the patient. So in the MRI, we could see a grade 2 patties retracted supraspinatus tear, which is almost grade 2 in fatty infiltration was also present in this patient. So these are the scans which I have shared in the PowerPoint. So there was also a subscapularis upper partial tear with long head of biceps tendon tear. And there was also an anterior labral tear for this patient. And there was thickening, and there was also a narrowing of rotator level. So in short, the patient was having a grade 2 retracted cuff with anterior capsular labral complex tear with frozen shoulder. So for the management side and the examination part, the patient had severe tenderness over subcoracoid and the biceps region, and his movements were severely restricted. His forward flexion were around 100, and further passive movements were also restricted. Abduction was 100, and passive was restricted. External rotation was 40 degree less than the normal side, and internal rotation was also restricted. His supraspinatus strength was around 3, and subscapulary strength was around 5. And the patient had apprehension at 90 degree of shoulder abductions, and O'Brien was also positive. So these are the shoulder movements before surgery. So the problems which we face was the patient has a secondary frozen shoulder after the shoulder dislocation and also the native bandaging. And he had a grade 2 gutlier fatty infiltration of supraspinatus with grade 2 retraction. And patient also had a symptom of instability. So coming to the dilemma about
Pramod, yes. What is the age of the patient?
50, sir.
50. Okay. Do you want to stop here and ask all the panelists about
Sure,
what
sir. I would like to ask the panelists what about the plan for this patient, sir.
So Clement, sir. We'll start with Clement, sir.
Clement, sir.
Sorry. So what is the main symptoms? Pain, right?
Yes, sir. Pain and weakness with restriction of movement, sir.
Okay. And usually when you have a problem like this, many times we have to rule out any axillary nerve injury. Did you do a nerve conduction study for this patient?
Yes, sir. Nerve conduction was done at the later stage when we presented to us after 6 months injury, and it was normal, sir. And its regimental watch was normal. There was no anesthesia on the lateral aspect of arm.
Okay. This age group, I won't worry too much about the instability, but I would like to know where the stage of the frozen shoulder. But if it's very acute, probably I would give an intra-articular injection to reduce inflammation and then mobilize him. Then we can do a couple of. If it's more than 4 or 5 months in duration, then probably the uh, frozen shoulder or has gone to the post-inflammatory second stage. At this stage, probably I will do a single stage procedure of releasing the frozen shoulder and repairing the cuff as a single stage as far as possible. If there is a major labral tear in this patient's, probably I'll put one anchor. I wouldn't spend too much time in addressing the instability because in this age, the instability is not a problem. One is rotator cuff integrity of your repair, that is going to be a question, and then post-operative stiffness is going to be a problem. And also, I'll warn the patient that he is more likely to, in case the patient's rotator cuff heals, but still he has a lot of post-operative stiffness, I will counsel him perioperatively that he may need a second procedure like a manipulation or an arthroscopic capsule release at 3 months of time. So that would be my plan in this case, Pramod.
What would you do for in the post-operative period? Would you immobilize or would you mobilize from day one? How would you do that?
Now, we will focus on passive, supine passive mobilizations. So normally our physiotherapist teach the patient to lie down flat, and we focus on regaining the external rotation passively, and passive supine elevation. The arm is brought towards the ceiling as the patient lies down, and the supine passive abduction by the attender or physio. So we focus more on supine mobilization, passive mobilizations by the physios and attenders, and we allow table level activities. Okay, within this range. Okay, you can eat, you can use the mobile.
Yeah. So these the supine assisted elevation and abduction you will start from day 1, day 2 itself, sir.
Yeah, 4 or 5 days down.
Yeah. I think very important points brought out. One is the axillary nerve. So you never so when the patient is coming with acute pain, severe pain, and so much restriction, don't ignore the nerve. And you did a good thing, Pramod, by doing a nerve conduction study as well. Yeah. So do you want to proceed, or do you want to hear Sundar sir's opinion?
Yes, sure, sir.
Sundar sir, would you do anything different or the same?
Sorry, I will do the same. I mean, I think Clement already had brought out all the point. So I was hearing only. So nothing much to add on that.
Okay, if anybody else wants to add anything, they can. Otherwise, you can proceed. Pramod, yes, go ahead.
Sir, so even I had the same dilemma, sir, whether to wait for the patient to regain his movements. But since already the supraspinal is like grade 2 retracted with infiltration is there, so I just wanted to do it. But only problem which I faced was whether to repair his labral tissue. And if labral tissue was repaired, how much of the shift I have to expect for this patient, and what to do for this frozen shoulder, whether to do any associated capsular release or not. So I was worried that if I do a like 360 capsular disease, already the patient has got an instability. Will it get worsened?
Okay.
So, but anyway, I proceeded with. So this was a diagnostic scopy. So can you see this, sir?
Yes, we can. Yes.
Yeah, so there was a lot of inflammation was there, and there was a torn long head of biceps, and there was an upper fiber subscapularis tear, sir. So I proceeded with the LHP tenotomy, because it was almost frayed and damaged there. But I again tried to elevate the labrum, but it was easily elevatable and it was detachable. So I thought, okay, we will anyway do an in situ repair rather than doing a complete capsular shift, so that we can over constrain the joint. So I just put 2 anchors there at the 5:30 position and 3 o'clock position and did an in situ labral repair for this patient. So, and I debrided the synovial tissue with a radio frequency probe. So I didn't proceed with a capsular release. So then I proceeded for the subscapularis repair using a single loaded anchor for the partial tear there, sir. So the supraspinatus, the quality of tissue was little bit on the poor side and it was retracted. But after complete mobilization and releases, I was able to bring it back. But I did a little bit of medialization of the footprint for getting a tension-free repair, and then I did a double row routine cuff repair, sir. So in short, I did a anterior labral repair with a subscap and a double row rotator cuff repair, but didn't proceed with a capsular release for this patient. So as sir mentioned, I started the patient on a passive range of motion, but I just started only on the forward flexion and external rotation, so that once external rotation regains up to 45 to 60 degrees, then I can proceed with the abductions. So I protected the patient with the sling for around like 6 weeks. So after 6 weeks, supine strengthening exercises were started. And once the patient was able to do gravity eliminating movements comfortably, then the gravity against gravity movements were started in standing position. So after 6 months, patient has got good range of motion movements. Even external rotation was almost comparable, and his abduction was also nearly comparable at the 6 month stage, and strength was around 4+. And he is still undergoing physiotherapy for his later strengthening, sir. So on the discussion part, I would just like to add. So first thing, as sir would mention, if it is patient is complaining with a persistent pain and weakness, even after 3 weeks of reduced dislocation, so one should be always prompt to do an MRI to see any associated rotator cuff tear was there. So I went there through the literature for regarding anterior shoulder dislocation in the elderly, mostly after 40 years to 60 years of age. So I could find out some literature where they have mentioned that the patients who have undergone only cuff repair for instability had instances of later dislocation in the future. So there was a cohort paper by Raparis et al., where they have mentioned the dislocation. Normally the shoulder is supported by 2 supports, the anterior support and the posterior support. So the anterior support, which includes the anterior labrum, subscapularis tendon, and the anterior rim of glenoid cavity, and the posterior support, the supraspinatus and infraspinatus. So most of the dislocation is either anterior based or combined anterior and posterior based. So in case of an instability, they are of the concept that if you do a posterior support, that is routine cuff repair, without a labral repair, there can be always a possibility of later recurrence of the instability. So I would like to mention that. So from my case, I was of the opinion that the results were better with simultaneous labral and cuff repair, because labral repair helps in bringing back the function of the shoulder. Cuff repair brings back the function of the shoulder, but associated labral repair can prevent further instabilities. And as mentioned, early range of movements are key to successful rehabilitation. And the secondary frozen shoulder can be improved with addressing the pathologies which led to the frozen shoulder, even without a capsular release in the earlier part. And recurrent instability is possible with cuff tear repair alone following traumatic dislocation in the early, sir. So this was my view from this patient, sir. So please, can you?
Fantastic presentation, Pramod. Any comments? Jaimin?
Yes, it is an excellent case presentation, and you have achieved good result as well. And I would like to just ask you a question, because you have gone through the literature.
Sure, sir.
would have been around 60 years of age, and he has a bony bank card or comminuted fracture of the anterior glenoid rim.
Yes, sir.
How would you approach him patient?
So it depends upon my thought process would be about depending upon the physiological age, the functional point of view, functional age of the patient rather than the physical age. If he's an active young patient like this patient which I was showcased, he's a 50-year-old, but still he is a physical education teacher with a lot of demand for him. And after CT scans, if the CT scan shows that the joint is getting of sublux, so I'll definitely go ahead with fixation of the bank guard. And also it depends upon how much the estimate the bony lesions, the bony extent of the bony injury. So if it is more than 10% and all, I will definitely go for a repair, even if the patient is after 60, sir.
So, Dr. Sundaraj and Dr. Karthik, if you want to add something, because we get
I think Pramod is excellent presentation and very good outcome. Very good outcome for the patient too. Yeah, of course, it's a big controversy. I think I completely agree with you. Even later on, I also found some dislocations patients. I mean, where I had repaired cuff alone, came back with dislocations. So nowadays, I'm also becoming more and more aggressive in repairing the labrum along with the cuff in most of my patients. The only problem here, this patient had a stiffness. That is the only concern for this kind of patients, where you went ahead and repaired the labrum also. Probably this case, probably I might have done only rotator interval release to get some external rotation. I think you are done in the subscap repair, whether with knowledge or without your knowledge. When you mobilize the subscap, definitely
I did a rotator clearance for this patient.
In the front of the subscap, in front of behind the subscap, rotator interval. So you are released already. So you told you, but you didn't do only capsular release. Because the rotator interval release and around the subscap releases, I think, help the patient to get back their movements.
I completely agree with Sundar sir. The 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 thing about stiffness following a rotator cuff injury or instability, when you say it is secondary frozen shoulder, basically you have to see how much passive movement the patient gets under anesthetic. Once the patient is anesthetized on table, most of these patients have full range. Okay, it's only when the patient is awake, he has stiffness. So that is not really primary frozen shoulder. I mean, it is secondary to the pathology, as you said. So did you do examination anesthetic in this patient? After anesthesia, how much was the movement?
Sir mentioned that after anesthesia, I was able to, he got an improvement in his range of movement, but it was not full range of movement, sir. But definitely there was an improvement in movement after anesthesia once the pain was eliminated.
That itself indicates that there is no stiff, thick capsule in the front. And as Sundar sir said, the culprit in frozen shoulder is the coracohumeral ligament. And the coracohumeral ligament resides in the rotator interval. So so when you do an interval release, which is part of the cuff subscap repair, you would have actually removed all the offending tissue, and that is how you got this excellent range.
Yes,
anything more to add? Anybody? If not, then
sir, I just had a query, sir. So if you find that the patient has a real stiffness even after anesthesia, do you still proceed with a capsular release in an instability patient?
Yeah, see, now when the patient is stiff, then the patient is not an instability patient anymore. You should understand. The patient has gone to a stiff shoulder now. It is not an unstable shoulder. You understand? So the capsule has become very, very tight. So in that patient, he needs mobility. So you might have to do a release, as sir mentioned. You have to do a release and then repair the cuff if you want. Or sometimes you can actually do a capsular release and repair the labrum. The capsule will actually form again. Okay. So if you think you have to repair the labrum, then you can actually put an anchor and repair the labrum, and you can still do a release of the capsule, which is a very rare and a theoretical possibility. But if the patient is stiff after anesthetic, then probably a release would do. You don't need to repair anything.
Okay, thank you, sir.
Sir, one last question by Dr. Vijayan Balakrishnan on YouTube chat. He is asking whether the movements were restricted due to frozen shoulder or poor cuff function. to Dr. Pramod.
So the patient had a primary issue of a cuff tear, so which followed with a native branch. I think it has went for a frozen shoulder following the injury which related to the cuff tear. So primary pathology was a cuff tear, so which was complicated with with inadequate mobilization following injury. So he ended up with frozen shoulder. So, and mostly it was due to pain, as Dr. Karthik sir told.
As Pramod said, I think it's most often this is because cuff pathology, because you see that the tear was very significant tear. And I think patient has a lot of pain and restriction of the movement. That's what
Yes.
Kati also mentioned,
Yes,
that you
yes.
examine after the anesthesia, because
Yes.
many of these patients, because of the pain, they will not be able to do the full movements. Even when you examine in the outpatient department, they will not go more than 70 or 80 because of the pain. And that's what we thought thinking about the stiffness, we may need to do a release or something. Under anesthesia, if you have a good range of movements, then we don't need to worry about the stiffness.
Okay.
This patient definitely is a more of cuff pathology, so definitely cuff has to be addressed.
Excellent. Can we proceed to the next talk?
Yes, sir.
Yes, sir.
Yes.
Naresh sir,
Yes.
are you visible, sir?
Yes,
Naresh
yes.
sir?
Yes, we are able to see your slide. Please keep
Yes,
it in
sir.
slide share mode.
Yes, sir. Good evening, sir. This is Dr. Mahesh from Karnool, sir, Andhra Pradesh. I would like to present three of my cases which I did in the last year. These are a series of neglected shoulder dislocations. Two of them are posterior and one of them is anterior. So usually neglected shoulder dislocations are defined as left untreated for more than 3 weeks. We can consider it as neglected shoulder dislocations. It's more of a challenging condition. When we face a neglected shoulder dislocation, we face the patient in locked position, usually unable to achieve a closed reduction. If we want to attempt a closed reduction or manipulation, we may cause a fracture. And even after 3 to 6 weeks, because of the disuse of the limb, osteoporosis of the bone, we can see. What are the challenges we face is we have to preserve the head in young patients in order to achieve good functional outcomes. The challenges are contracted capsule both anteriorly and posteriorly, fibrosis in the glenoid joint and in around surrounding the humeral head, bony lesions both in the humeral head and in the glenoid, and sometimes post-operative instability even after good fixation. In surgical technique, I used to prefer B-chair position and deltopectoral approach, bicep stenotomy, coracoid osteotomy if needed, subscapularis take down if needed, and preparation of the glenoid in order to receive the humeral head, reduction of the humeral head, and repairing of the rotator cuff and tightening the muscles. Okay, coming to the position, it is a B-chair position, deltopectoral approach. And while doing these neglected shoulder dislocations in both anterior and posterior dislocations, we have to be very careful while doing medial releases or medial work, because we have to take care of the neurovascular structures, both the brachial plexus and the arterial system. And this is the subscapularis takedown. We can cut the tendon over the attachment to the lesser trochanter, and then we can reattach again after the work. Coming to the cases, this is the case one. Is a case of neglected posterior dislocation. Is came with 6 weeks post dislocation in the same position. Went to native treatment. Came with the locked shoulder. Neurovascular examination is intact. This is the patient at the presentation. He is unable to do any movement of the shoulder joint and the injured shoulder joint. And this is the MRI. He came with the MRI to me and CT scan video. So I kept the CT scan picture over here. This is the neglected 6 weeks old posterior shoulder dislocation. And this is the MRI. In MRI, you can see the dislocation posteriorly here. This is the initial presentation. We can typically assess the light bulb appearance of the posterior shoulder dislocation. And coming to this is the post-operative X-ray. I did a open reduction and the McLaughlin procedure with the subscapularis double breasting. And this is the patient after 3 months. Full range of movements, abduction, elevation, internal rotation. And this is the video. చేతులు రెండు పైకి లేపండి పైకి రైట్ కిందకి వెరీ గుడ్ కిందకి వెనక్కి తిరగండి చేతులు రెండు వెనక్కి పెట్టుకోండి వెరీ గుడ్ తీసేయండి స్ట్రైట్ తిరగండి చేతులు కింద పెట్టేసేయండి ఆపరేషన్ ఎన్ని మంత్స్ అవుతుందండి వెరీ గుడ్ ఇబ్బంది ఏం లేదు కదా థ్యాంక్ యూ సో మచ్. This is regarding case 1, sir. Any questions, sir? Naresh, sir?
Mahesh, please continue. At the end
Yes.
of the talk, they will ask question. Anything is there?
Thank you, sir. And coming to case 2, this is a case of 3 months old injury. He came in the first attempt when he got injured. This is the fracture dislocation of the greater trochanter, greater tuberosity. And after this, we have advised the operation initially. The patient went to quack treatment and came after 3 months. We can see the blunting of the edges of the humeral head, and the entire greater tuberosity is placing over the glenoid bone. We can appreciate it here, sir. Or the entire glenoid is occupied by the greater tuberosity, and the head is dislocated posteriorly. We can see it here. And he came with locked shoulder, and neurovascular examination is intact. And he is a non-alcoholic, and he came with a very locked shoulder. I operated him. I just want, because considering his age, he is just only 31 years old. I just want to retain the humeral head, and I just want to retain the greater tuberosity and the tendons. So supraspinatus tendon and infraspinatus tendon. So I have put a plate over there and tied sutures and released the greater tuberosity and kept over here, and sutures is tied over the plate. And this is the follow-up X-ray after 3 months. Even though the greater tuberosity has been dissolved, but the patient is able to do active movements. This is the range of movements we can achieve after 3 months. Very good. Operation very good. Operation 1.5 years. Very good. He came for plate removal after 1.5 years, sir. This is case 3. This is a case of anterior shoulder dislocation, 4 weeks old, greater GT fracture dislocation, and we can appreciate the subcoracoid type of anterior dislocation. He is a non-epileptic, but he came with anterior shoulder dislocation, neglected and intact neurovascular structures. This is the present CT at the time of presentation. This subcoracoid type of dislocation with dislocated GT fracture, and I have operated him with subscapularis takedown, repair of the subscapularis with anchor, and even after repair of the subscapularis, even after the repair of this supraspinatus and GT with plate, it is again dislocating. So I have kept a caver initially, and caver is removed after 4 weeks. This is after 4 weeks X-ray, and he is the patient after 1 year. Range of movements is this much. Very good. Very good. So take home message: summary of neglected fractures. Preoperative evaluation imaging is must. And we have to know the expectations of the patient in the dealing with the neglected fractures, like after 6 weeks or 3 months. And backup idea is must. If we can't get any reduction, or if we can't get the sutures of the tendons back into position, backup idea must be there. And dissection part, we should not go too medially because of the neurovascular structures, brachial plexus, and the arterial injuries. And do not hesitate for the coracoid osteotomy if needed. We can fix it later after our work is done. Young patients, whatever may be the fracture, whatever may be the condition of the bone, try to maintain the native heads, and whatever reduction we achieve, try to maintain it. And we can delay the range of movements in neglected fractures even after 2 to 4 weeks. Thank you, sir.
Thank you, Mahesh. It was excellent presentation, all the three cases.
Thank you, sir.
Yeah, would like to know one thing. In neglected posterior shoulder dislocation, you have not mentioned about the reverse Hill-Sachs lesion.
Yes,
Was it
sir.
there, and what did you do for that?
So, reverse Hill-Sachs lesion, I didn't take on it, sir. Just I reduced the humeral head into the glenoid after subscapularis is taken, and I just sutured back the subscapularis tendon like McLaughlin's procedure, sir.
Okay.
And the reverse Hill-Sachs, what I have observed is of minimal only, sir. Not much of bone loss on the humeral head.
Perfect.
Yeah, what you said is the McLaughlin's procedure is exactly what you need to do for the reverse hill sack. So
Yes,
I
sir.
think what you have done is you detach the subscap and you medialize the footprint of the subscap. You
Exactly,
put the
sir.
you put the subscap into the reverse hill sac, which is basically just medial to the lesser tubercle. So that's
Yes,
exactly
sir.
what you should do. Sometimes what you can do is you can osteotomize the subscap along with a little LT, and you can put the LT into that defect if you know it pre-op that there is going to be a defect.
Yes.
So I think you managed pretty well all the three cases, but the last case for the anterior dislocation,
Yes,
it
sir.
was a 4-week-old dislocation, right?
4 weeks old dislocation, sir.
And still it was quite unstable.
Quite unstable even after reducing the GT fracture with suture fixation onto the plate, sir. So I have kept a K-wire for 4 weeks and removed immediately after 4 weeks, sir.
So that is not a bad thing at all. You can actually keep a temporary wire. The wire can be you can actually keep two wires,
Okay, sir.
one from the humerus to the glenoid, and one from the acromion to the humerus.
Okay,
So
sir.
you have to the important thing is you can't keep thin wires. The wire has to be at least 3 mm thickness, 3 to 4 mm, because it can easily bend or break. If it bends or breaks, then you are done. It's a very difficult thing to remove. So keep a thicker wire, usually a sand screw, which is about 3 to 4 mm in dia, and you can remove them under local anesthetic in the OPD setting at 4 weeks to 6 weeks, depending upon this thing. The one thing you can do is you need not tenotomize the subscap when you do the anterior dislocation. You can actually open the rotatory interval, put a finger, and actually you can reduce it. You don't need to tenotomize the subscap. If for a posterior dislocation, you have to do it because you're going to medialize the subscap into the Hill-Sachs defect. For an anterior dislocation, you can do it through the rotatory interval. But what you had done was commendable. Thank you for the good presentation. Any more points to
Thank
add?
you.
I have a question regarding last case, sir. So since it is a
Yes.
locked anterior dislocation, which was even in subluxating after repair of GT and the cuff tendon, why can't we add a Latarjet procedure since it's almost, there can be a glenoid bone loss following the dislocation, right? That's why it's still unstable, or is Latarjet can be done for this patient along with the repair?
My concern is, sir, he is a known epileptic patient, and thought of adding a bone block procedure at that time. So I kept I think thought of keeping a K-wire, and we'll see later, like that I thought, sir.
There is nice paper from Gilles Walsh. He mentioned that if you add Latarjet, usually the results are not good. It becomes more painful. Chances of implant failure and all those things are more chronic pain post-operatively because you are sacrificing the subscap. So the sling effect of your Latarje won't work.
Yeah,
Yes, sir.
yeah, I agree with Jamie. But what Pramod pointed out was that you should be aware of the anterior glenoid bone loss.
Yes.
So when you are when the patient is chronically dislocated, especially in the subcoracoid position, the patient might actually be moving the shoulder, moving the humeral head, and the humeral head will be eroding on the glenoid, and it would have eroded a significant amount of the glenoid. I actually saw a 80-year-old lady with almost half of the glenoid gone. So in that case, if you reduce it, it's going to be unstable again. So you'll have to keep something in mind to augment that glenoid at some point. So I think that should be kept in mind as well. As far as doing a Latarje in a neglected anterior dislocation, actually I have done a couple of cases, and touch wood, I've had good results. The problem is, as Jamie said, you actually cut the subscap. Now, if you cut the subscap, you have to reattach it, and then you have to split it, and then you have to put the graft in through the split, and you have to hope like hell that your graft will heal and the subscap will heal. So that's too much of tension on everything. And thankfully, in my cases, it worked. But I agree that it might not work, even in the best of hands, especially in an elderly patient. We see a lot of these in elderly patients. So there you have to be a little careful, even in the setting of an anterior glenoid bone loss, whether to combine it with Latarje or something else, like Eliocrest might be a better option. Excellent.
Thank you, sir.
Jamie, anything to add? Naresh?
No, sir. No, sir.
Yeah, few things. One, these are
Okay.
all the three cases were relatively, I think, 4 weeks, 6 weeks old. Only one case was, I think, 6 months old. So all
3 months old, sir.
3 months old. So if you see more than 4 months, 6 months old, these are very disused osteopenia is there. So you when you try to reduce, even after doing good release, tenotomy, coracoid osteotomy, and still when you apply rotational force, there are always chances of fracture. So you need to be very careful, and you need to have in backup with you all the plates, and even hammy should be ready on the backup. That was one thing. At the same time, in very acute cases, when they present around 3 to 4 weeks, we have done few cases where we just put a shank pin inside and we have reduced it successfully in GA without using much force. And there are techniques of posterior shoulder dislocation. So with that, you can even reduce without opening that. So two things I would like to add.
Thank you,
Thank you,
sir.
sir. Any more questions anyone need to ask? Right, sir. Jaimin, sir. Sir, there is one, excuse me, sir. There is one question in YouTube chat by Dr. Jishan Khan. He's asking, can letter jet could have been done if there was instability?
Uh,
Yeah.
depend. Yeah. Mahesh, any answer for
Yes,
that?
sir.
Already, I
Yes,
thought
sir.
I already explained.
Actually, the thing is, sir, for this question, I have tried the same what Karthik sir said, like rotator interval was opened and tried to reduce with the finger and into the glenoid bone, but it is not very difficult and lot of fibrous tissue was there, even it is 6 weeks old. Lot of fibrous tissue is there. Then after all the options, I tried of doing the subscapularis release. Then I took off the mind that not adding letarget to this procedure, so I have kept a K-wire. That's the reason I have not done a letarget, sir. Because once I've opened the subscapularis, adding a letarget is not good in my mind.
Perfect. So again, Dr. Karthik has mentioned that he did added in few cases. Even I have done Latarje in one of the cases. So, but if you see the literature, it's slightly diverse, and you should get done 3D CT scan and have a look at the bone loss, glenoid bone loss, before you go inside. So you can be ready with the ICBG graft if required.
Sure, sir.
So, Dr. Naresh, yeah.
Sir, if there is no further questions, I would like to ask the moderators to end this session.
Thank you. So, thank you, Dr.
Thank you, sir.
Naresh. Thank you, IS, for this opportunity. And we have got excellent surgical technique demonstration by Dr. Clement Joseph, and excellent case presentation from Dr. Pramod Mohan, which gives us insight of how to look after anesthesia regarding the stiffness. We do get such kind of patient very regularly in our practice. And when you put a scope, you need to read the biology. It was, if you see the red hot capsule, and you need to take a decision, as Dr. Sundarajan explained, that you can release rotary interval just to be on safer side, and you can start early range of motion. And regarding all the three cases presented by Dr. Mahesh, we had a good discussion and things to be kept in mind for you need to prevent any further injury to neurovascular structure, that is of prime importance, and you need to have a backup plan if something goes, if it gets complicated. So with well-read and well-executed cases. Thank you, IS Naresh, Dr. Naresh. Thank you.
Thank you very much, sir. Thank you.
So
Good
I will
night.
take the opportunity to thank Dr. Naresh sir for giving the opportunity for presenting this case, and also the Indian Arthroscopic Society. Thank you, sir.
Thank you. Thank you, sir.
Thank you, Naresh sir, for giving the opportunity on the Indian Arthroscopy Society. Thank you, sir.
Thank you, Mahesh.
Thank you,
Thank you,
sir.
sir. Thank you.
Thank you. Please.